Foundation, and we're here to share with you our Men's Health Survivorship series. And tonight's event is going to be a fantastic one, and we have a fabulous guest to talk about the role of active surveillance. But before we get into that, I want to talk a little bit about our foundation events and how successful they've been. In fact, this past weekend, we just had our annual Men's Health event at Ford Field with over 1,750 attendees. And this year's event was special in so many ways. Besides the number of men that took advantage of the screening opportunities, it's the screenings that we offered that made it a very special event. At this year's event, we not only did PSA screening for prostate cancer, but every individual had access and was prompted to get a test, which is a liquid biopsy test supplied by Ren Labs. And all of the men who had these tests performed will actually get follow-up care with local urology services here in the greater Detroit area. In addition, we performed some special blood work, one of them being lipoprotein A. And for those of you who don't know what LPA or lipoprotein A is, it's LDL's bad brother. And it's one kind of test that tells us if your LDL bad brother is elevated or not. And if you have an elevated lipoprotein A, you hit the genetic lottery in the wrong direction. And this is one of those blood tests that you can't eat your way out of it and you can't exercise your way out of it. So if it is elevated, you might need to get some special treatment to get that lowered and improved to reduce your risk for heart attack or stroke. So we're very excited that our men's health event has taken place. It's completed, and we're moving forward into now our men's health survivorship series for today, which I'm very, very excited about. This event wouldn't take place without our sponsors. This event sponsors are Lantheus, Blue Earth, Corewell Health, Neil King Physical Therapy, and the American Cancer Society. I want to thank them for actually sponsoring this event and allowing us to have this platform to share. As you know, our guest tonight is Dr. Todd Cohen. He's the former CEO of the Carolina Urology Partners, a large urology group practice. He's also the former medical director of Myriad Genetics, and he's now the vice president of medical affairs at Blue Earth Diagnostics. Dr. Cohen, welcome to our event this evening.
Thank you. Thanks so much for having me, and congratulations on your event. That's fantastic.
Thank you so much. And, I'm really excited to have you here today. Our topic tonight is active surveillance. And what a lot of people don't know is that there are 3 million men in the United States presently on active surveillance. Even though the incidence of diagnosis is about 300,000 a year, a lot of men end up on active surveillance. And it doesn't mean no treatment, it may mean just delayed treatment for many men. And I think we'll talk about that in a little bit. One of the things that's made active surveillance actually a wonderful choice for so many men are the advancements in the tools and technologies, which I'm going to have Dr. Cohen discuss with us tonight. Some of it will be some of the genetic testing opportunities for men, and as well some of the advancements in imaging technologies. So I was going to have Dr. Cohen explain to me a little bit briefly about why it matters, some of these tools, and why does active surveillance really matter?
Well, Mike, I think that the important thing is you kind of hit it on the head, is that we diagnose about 300,000 new patients a year with prostate cancer. The vast majority of those patients won't die from prostate cancer. We've seen that over the course of time and following it. And I know a lot of people think, well, I have cancer and I have to be treated. But there are some indolent cancers, and prostate cancer in some cases is one of them. So we've learned over the past 20 or so years that there are some prostate cancers that can either delay treatment and may not progress on and become lethal and kill a patient. So this whole technique of active surveillance or actively watching patients has developed. And as you stated, it's really not just go home and watch it and we'll see how it happens. But as I used to tell my patients, it's a form of treatment. It's something we're going to do and keep a very close eye on you, so that if it looks like your cancer is progressing or moving on, then we can act. And we can avoid, hopefully, for either a delayed period of time or forever, any potential bad side effects to treat something that may never have caused a problem in the first place. So it's really taken hold, over it's 2025, or probably since the early 2000s, when people started getting that idea of, gee, we don't have to treat everybody, aggressively that has prostate cancer.
There are a lot of code words that people use, active surveillance and watchful waiting. Is there a difference?
Sure. Yeah. Watchful waiting is that, gee, you're old, you have other comorbidities, you've had 5 heart attacks and things like that. Your prostate cancer is never going to really cause your problem. So instead of us watching you and doing repeat biopsies or lots of imaging and spending a lot of time, go home. And if you have symptoms or something, then come back, or we'll keep a light look at you. Whereas active surveillance is exactly what the name infers is it's active. I mean, we're doing things. We set up a protocol. We have men come in at regular intervals for repeat PSA checks and for imaging studies like MRIs, and also repeat biopsies to make sure that what we found initially that may not have been aggressive, that we doesn't become aggressive. And what a lot of people think is that my non-aggressive cancer may morph or change into or develop into an aggressive cancer, which is really probably not the case. It's more likely that there might have been an aggressive cancer that was undetectable or just so small initially, and that starts to grow. That's why you can see this progression. It's not the old indolent cancer. It's this one that was there smoldering, and all of a sudden it starts taking off or it starts growing. And then we can detect that later on. And until that becomes the prevalent form of cancer, might not need to do anything more than keep a close eye on these men.
I'm going to try and avoid from jumping all over the place because there's so much here in
Mhm.
this discussion.
Absolutely.
But if we go back to 1986, because that's the year I went into practice,
Mhm.
there were only 3 urologists in the state of Michigan that were doing ultrasound guided biopsies of the prostate and prostate cancer screening using PSA technology. And I was one of those 3. And now, I mean, it's everybody. And the thing that happened during the early years of my practice was this development of a knee-jerk reflex of elevated PSA biopsy. And that was the world we lived in. And then came the bad rap. Screening got this incredibly bad rap. Active surveillance wasn't really in existence at that point, and then the U.S. Preventative Service Task Force kicked in. Can you share with me a little bit about your thought about what happened during those years and kind of how we reacted and how perhaps we went in the wrong direction?
Well, I think you're right. PSA came out in the early 80s and was really prevalent as a screening tool by the mid 80s. And the problem is we were detecting cancers so much earlier. Prior to having a screening blood test, the only way to really detect cancer was, on a digital rectal exam, feeling a prostate and seeing if there was a nodule or something, or finding it because it had already spread and metastasized and it was causing bone pain or something else like that. And that's how we discovered it. So back in the 80s, when we had this blood test now that was associated with cancer. So if you had prostate cancer, this blood test, the PSA, was noted to be high. Well, that, like you said, started kind of a revolution where everybody was getting this blood test. And if it was thought to be high, they were getting biopsies. And we were finding all these men now that had prostate cancer. And we really didn't have a good feel or good grasp on which ones were harmful. Or, and I think the best way to say it is which one could potentially cause a person to die. We all thought, back when I was growing up, and Michael, we're probably, when we were growing up, if you had cancer, it was the C word because everybody that had cancer died, or that was our thought anyway. But that's not the case anymore. And we have a lot better tools and we have a lot of better diagnostics to find it earlier so we can treat it. And most people actually, they get cancer, whether it's prostate or others, survive their disease these days. So when we found too many of these cancers in the 80s and 90s, we were treating everybody because that's what you did. And then studies started coming out, a lot of them from Europe and other places that said, gee, if we don't treat certain men, they're going to do just as well. And then it became an issue, almost an economic issue, is that we are finding so many men, we're treating everybody, but we don't need to. So we're probably over screening for prostate cancer. Then the wheels kept turning, and there was decision to made to really kind of abruptly say, well, we probably shouldn't screen at all. That the screening for prostate cancer using PSA was given a D rating, and especially most doctors who I consider overachievers to begin with, you're stamped as soon as you get into medical school, you get that overachiever stamp on your forehead, and nobody wants to get a D on anything. So when you see a D, you're like, oh, this is bad. We got to stop doing it. and it really spread like wildfire, a lot of which was spread through the primary care, who are the guardians of of patients. And if they're the screeners primarily, people don't come to a urologist right off the bat to be screened. They go to their primary care. And the primary care sees this government agency saying, gee, screening for prostate cancer is a D because everybody doesn't need to be treated. And all these urologists are treating all these patients. We're overdoing it. And we're doing more harm than we are good. So the screening went there, it plummeted after the determination came out from the government. And we're feeling the repercussions of that now.
Oh, we sure are. Just to give people some perspective, pre-PSA, which was before the mid 1980s, the annual diagnosis of prostate cancer in the United States was about 75,000 cases a year. After PSA was implemented as a screening tool, we went up to over 200,000 cases a year. We found this incredible reservoir of men with disease because we had the tool to find it. And then we started going through the screening process of finding all these men. And in those days, it was a knee-jerk reflex, as I said before. It was elevated PSA, biopsy, and then it was treatment. And we've gotten smarter, so much smarter, and we've developed so many tools and options that have allowed us the capability to really differentiate uh, when we have an elevated PSA, what is the next step? And when the next step is perhaps getting a liquid biopsy test, and then maybe an MRI, and then maybe a biopsy, then we have the technology to say, is this man warranting further investigation? And then is treatment going to be indicated? So we keep improving our technologies and increasing this paradigm of care opportunities so that we don't overdiagnose and we don't overtreat. And I think that because of that, I think you could share a little bit about, if you look back at some of I think the PLCO data, the original screening trials, which have been carried forward through Europe, the European trials as well, to this date. I mean, that data is pretty fascinating, don't you think?
Absolutely. I mean, there's the data on the screening, and there's also data that look at what's the natural course of patients that are either put on active surveillance or treated with the most common modalities, which are either surgery or radiation. And you look at how those men do over time. And some of that data is fascinating, and most of which of that information comes out of Europe as well, looking at surviving cancer with either without treating, putting them on active surveillance versus those men that are treated with radiation or surgery. So, like you said, not only do we have advances, but we've had time in the PSA era to look at what's happening, and I think you're absolutely right. The numbers have gone up of detection have gone up astronomically because we can find it. And which again, as I mentioned, I use the term blessing and a curse. It's a blessing because we can find it. You can find occult cancer early. It's a curse because we can find occult cancer early. And some of those, but now we understand a lot better. We're not perfect yet. Who we need to treat and who we can either delay or not, or not treat because in some cases the treatment is worse than the disease.
But you were mentioning a little bit before about the treatment and the diagnosis. Um, we've had a lot of men who would be diagnosed and then treated, and then there was this mixed message as to what's the right way to do. How did this play into your personal management of these patients in your practice when you were diagnosing men with prostate cancer?
Well, you know, I used to when I diagnosed men with prostate cancer, you look at their disease individually because prostate cancer is a spectrum of diseases. It's not you have it or you don't. So everybody that came in individually when I saw them would have a consultation, and I always thought it was really important to spend a lot of time because it's such a unique cancer. And there's so many different treatment options that I always had them come at the end of the day, and always bring a family member. And it was always my line is bring your wife or bring a daughter with you because most guys are terrible at asking questions. So if you bring your son or just yourself, you're probably not going to ask the questions that need to be asked. So always bring a family member just to, clarify. And then we sit and we talk about the results. We talk about everything that led up to the biopsy and the results of the biopsy. And we went over things which we'll probably talk a little bit about during this cast, about the grade of the tumor or how aggressive the cancer looks under the microscope, the stage of the tumor, where is the cancer in space? Is it just confined to the prostate? Is it potentially outside of the prostate? And then go over from that the treatment options. As time went on and my practice developed, and I started my practice in the mid 90s, and left practice in approximately 2020, right before the pandemic. But you know, a lot of things occurred in that time frame, in those 25 years, where we had, and you mentioned genetics and genomics and improvement in imaging and all of these things you can talk to the patient about and use all the information to make the best possible treatment option. And which one of which evolved was this idea of active surveillance. So it was a long discussion. I used to do at the end of the day, people come in, you're staying until you have no questions. And if you stayed for 2 hours, so be it. It was something that was necessary, for especially for these men, because it's a complicated thing. It's one of the few cancers. There's not a black or white. Even if you look at guidelines and things, there's arrows and things pointing in every possible direction. So there's no one right answer for anybody. So you have to look at every individual with all the information that you have.
We've recently had two examples. You mentioned the COVID pandemic. There's two examples that have impacted the diagnosis of prostate cancer. One was the change in guidelines and recommendations from the USPSTF, where they said derating, don't do it, and gave us age criteria of what age range to do it. And we found since that there were fewer men screened, and we found a higher incidence of higher grade, higher stage disease on those men who were then getting screened for prostate cancer. In addition, during the COVID pandemic, there were 25% fewer diagnoses of prostate cancer during 2020 as a result of people not getting and not seeking out healthcare. And as a result of that, we found more higher stage, higher grade disease subsequent to the COVID pandemic. And I'm not even sure we've fully ferreted out all of the diagnoses out of the woodwork. And if you look at the statistics of the rising incidence of prostate cancer in the young and the older population now, of about 4% per year, and the fact that the incidence of prostate cancer is going to double by 2040, we have a very serious global epidemic on our hands. And I think that it's going to be up to people like you and others to find ways to delve into the community and get the word of screening out, and so that we can continue on the opportunities of active surveillance for those who are candidates for it and treatment for those who are in need.
Yeah, no, I agree. I think just like any kind of cancer, early detection is so important, because even men that have aggressive cancers or harboring aggressive cancers, our ability now to identify these men is getting better and better. I wish I could say we're perfect, but we're not. We're still working on it, and we're still learning about the disease. But if the earlier we can find it through, appropriate screening methods, um, the better impact we'll have. And yes, because we didn't have the screening, whether it was COVID or the USPSTF determinations, which have improved, but they're still not great. We're going to do better. Hopefully, we'll make a dent in the rise that we're seeing. And I'm hoping that this will be a blip or a rise, and then we'll see it come back down. But we don't see the evidence of it coming back down yet. I
Right.
still think we're that rise phase, which is scary.
Well, there's no question the screening guidelines have to change because
Yes.
they don't take into account all the advances in liquid biopsy technology and the imaging technologies that are upon us at this point in time. Just
Mhm.
as a quick aside, I cannot tell you how many people have turned to me and said, "Well, what do you think about Joe Biden?" And what I tell people is that if you look at every single screening guideline that is in existence at this time, that after age 70, you don't get screened. It doesn't
Right.
exist. It's as if you've aged out. And I call this diagnostic ageism. And it's really almost criminal that we allow men to not get screened if they have at least 10 years of survivorship on their bodies. And the other thing is that we expect about 8% of men a year to be diagnosed with metastatic prostate cancer with the way we are screening at this present time. Well, that's 15,000 men a year that we're saying it's okay to have metastatic disease and we know you're going to die from it. And that's just not acceptable, I think, in the United States or anywhere in the world. And we have to do better and we have to change what we do to really make sure that we don't accept 8% of our population to have metastatic disease at the time of diagnosis.
Right. I mean, I agree. I mean, you know, metastatic disease is terrible. Men die from metastatic prostate cancer. You can delay that, but you can't cure it. And at this point, we just don't have the ability, with modern, treatment techniques to cure metastatic prostate cancer. So the idea is, if we are finding too many men that are metastatic at diagnosis. There's no question about that. And early screening will help that. Will bring it to zero, hopefully, if we can find better screening methods earlier, um, and use them again appropriately to weed out those guys that will be metastatic. If we can get rid of the metastases and we can treat before it becomes metastatic, that's the win right there.
I
And that's what we need to do.
So, to getting back to active surveillance, I know I'm kind of going all over the place because I get kind of crazy and passionate about some of these other areas. Who do you think is the ideal patient for active surveillance, and how do you select them out?
There are a lot of ideal patients. I can't say there's one particular one. Everybody says, well, I'm too, if you're young, if you're in your 50s and you get diagnosed with prostate cancer, people say, well, I'm too young because I have a lot of time to develop worsening disease. But also, if you look at it, there you have a lot of time to not have the side effects if you didn't need to have the side effects from some type of treatment. So age in itself, I'm not going to say is a pure um, be all end all of who should be on active surveillance. So even like you were saying, older men, 70 plus years old, and they get diagnosed with prostate cancer. I mean, some of them will have aggressive disease. They don't have to be put on active surveillance. So the ideal candidate is somebody that, regardless of age, that has lower risk disease. And I use the term lower because low is a certain risk category that is defined, but lower risk disease that shows no evidence or is very unlikely to harbor metastatic disease. And the patient also has a life expectancy that is either good or it's maybe they have other comorbidities. But to the point where if it's low risk, so it's not likely to become metastatic, those are great candidates, whether they're 50 or 45 years old or 80 years old. They're good candidates for active surveillance. But they also have to be willing to follow the protocol, to stay in that active surveillance where they're going to come back and follow up and not just say, well, my cancer is not bad, so I don't need to do anything. That is also important, is that if when I would have a patient that came in and they were great candidates for active surveillance, but they were unreliable, I was really hesitant to put them on active surveillance because I knew they weren't going to come back. And I was worried that if they didn't come back 2, 3 years down the road, that they would come back with metastatic disease. So this is also, yeah, if you take that individual's, you know, likelihood of coming back or following up and following the protocols into account as well. So that was always, always part of the determination. But I really think that anybody, we've shown, with genetic studies and other more advanced studies as well, and imaging studies, that we can really identify these men that aren't harboring occult metastatic disease, have lower risk disease, so they're less likely to have progression. And we can watch them. And how long can we watch them? Indefinitely. I'll give a little anecdote. Is the first time I really thought about active surveillance, I had a gentleman come into my office. He was in his early 50s and he had an elevated PSA, and I biopsied him. And this was 2001 or two, where the concept of active surveillance wasn't even a thought at that point. But he came in and I biopsied him, and he had something that we don't even talk about these days called the Gleason 5, which is about as low a risk. It doesn't even exist anymore. Nobody even diagnoses Gleason 5. And for those of you listening, that's just an incredibly low risk disease. And he came in and we started talking, and I'm sitting there going, okay, I got to either take this guy. He's 50 years old. I got to take his prostate out, or he's got to go to the minimum for radiation. He just looks at me. He goes, "What happens if I don't do anything? If you just watch me?" And I look at him. It goes, I said, probably just these exact words, dude. You've got cancer. I'm obligated, I've got to treat you. And he goes, well, what happens if we put it off? We just watch it. And I'll never forget this because this was um, in 2002-ish, and I was still following him and watching him. He was one of the last patients I saw when I left practice in 2019. And I was watching this guy for 17 years, and his PSA literally went from about 4.1 to 5 over that time. I probably biopsied him because I was nervous 5 or 6 times over that 18-year period, and it never fluctuated. So that was my first encounter. And then I realized, yeah, he's got something here. And, I'm not going to say I invented active surveillance by any means, but that was my first encounter. And I said, this is something that we can really do, as I saw him year after year after year.
Well, it was pretty cool that you selected patient zero for active surveillance. Uh,
Yeah. They
one
didn't,
of
they
the
didn't,
things that
I thought they were going to call it Cohen surveillance, but that just didn't catch.
One of the things that also needs to be addressed in active surveillance is a man's psychological status.
Mhm.
Because when a man is diagnosed with prostate cancer and placed in active surveillance, the incidence of anxiety depression is about 2 to 3 fold. And I think it's really important that if a man is already anxious or depressed, even before they go on active surveillance, they may not be a good candidate for active surveillance. And if you're not sure, getting a consultation with a psychologist and doing some counseling might be really worthwhile as a preventative service for this individual. And I always like to throw that out there because a lot of times as urologists, we don't think about that. We always focus on the prostate and forget the rest of the patient, and that's really not fair.
Yeah, absolutely. And even if we look at the data of who stops their active surveillance, it's not always because they're progressing. It's not because their PSAs are increasing. It's not because the repeat biopsies or the imaging shows progression. A lot of it is just that is I've had cancer for 3 years and I'm getting, I'm worried that something bad is coming. And they
So as you
stop
know,
it because of anxiety.
imaging technologies have actually changed significantly since we both went in practice. How
Mhm.
how how are the new imaging technologies and modalities a benefit over what was?
I'd say the biggest change and probably is the advent of prostate MRI. I would say is probably the most impactful thing in imaging that's come out. I'm not. I'll say there are other ones, and I'll talk about those in a second as well. But initially the prostate was just imaged using ultrasound while we did our biopsy. We didn't do any kind of imaging to try to detect where the cancer was before we did a biopsy. We just went in with an ultrasound. And the problem with ultrasound when I was doing biopsies, and some of the technologies improved, but basically less than half, for about half of prostate cancers, looked identical to the normal prostate. So we just kind of took our segmental biopsies, so we covered a good portion of the prostate. And there was a good chance we missed the prostate because you put these little needles in that are about the size of a blood draw needle to get a little specimen out. And yes, you take a lot of stabs, which was kind of nasty, and it's never fun for anybody. But you didn't get a good coverage. You didn't know where you were targeting. Then came prostate MRI, and that changed a lot of things. Initially, MRI was done after you had the diagnosis of cancer to restage a patient. In other words, you found the cancer using your ultrasound and your biopsy. Then you had an MRI to make sure it wasn't outside of the prostate because you've got a good anatomic feel, or if there was some identification of lymph nodes that you may, see. But that was done after the diagnosis. They started moving it and looking at it to use it prior to the biopsy and using it not only to see if there are areas suspicious for cancer in the prostate, but where they were, and using the MRI to help guide where you're taking your biopsies from. And that has improved the detection of significant cancers greatly because more advanced cancers, more aggressive cancers tend to show up better on an MRI than the less aggressive ones. So that helps solve two problems. One, it helps us identify with more accuracy where we're taking our biopsies from, as well as giving us the anatomic approach. Is it outside the confines of the prostate? It also helps us do on the opposite end is we don't want to find those cancers that are not aggressive, that aren't going to hurt anybody, because all it does is cause anxiety and questions of what we do with those patients. And so we're finding a lot of men that have more aggressive cancers. Hopefully, we're not finding those men that have the indolent cancers as much, which are the ones, typically are good, would eventually be, with all the other factors involved, be cancer for active surveillance. So that has changed things dramatically as far as the diagnosis. It's been just a great addition to the armamentarium of diagnosing prostate cancer more accurately,
And what's
and also
really
for staging.
And
Yeah.
what's really cool is that the standard of care for the last 5 to 10 years is using what's called a IV enhanced multiparametric MRI, which is about a 45-minute 2 and 1 hour study. But more recently, in the last year, has been the usage of AI enhanced biparametric MRI, which are non-contrasting, which is a 15-minute procedure. And so if we now, and they've been shown to be non-inferior,
Mhm.
and in times even superior in some studies. So I think that moving forward, the technology will be that men can get these quicker and easier MRIs to look at their prostates. And perhaps this will be a really excellent tool for active surveillance. When you were in practice, did you use MRI imaging as an active surveillance tool?
Um, in so much as I used it to follow when we made the diagnosis, and you're going to follow the men, is getting repeat MRIs either prior to a confirmatory or surveillance biopsy. So yes, we would get the MRI first, before the diagnosis, and then we would get subsequent MRIs as well. So yeah, we did. And I think these days you can't have a conversation about technology unless you mention AI. And I think AI is there's so many subtleties that we can't visually detect, that AI will be able to detect. So I think you're right. I think we're only going to get better and better at looking these things. And will we be able to move forward, with, eliminating invasive biopsies and using imaging techniques to detect cancers? I mean, the analogous to kidney cancers. We
Yeah.
typically, when you diagnose somebody that has a kidney cancer, it's a radiologic diagnosis. So what it looks like on an X-ray. It's very rare that you need to get a biopsy and have to do something invasive before you start your treatments. And hopefully, we'll have the technology in the near future that show equivalency to invasive biopsies to be able to detect not only that there's, yes, no cancer, but what kind, how aggressive, what does it correlate to in the biopsy, be able to look at it radiologically, which, whether it's MRI alone or in conjunction with other technologies for imaging.
Well, that's what I wanted to ask you a little bit about because in addition to MRI, has been advances in what's called PSMA PET technology. Can you talk a little bit about what that would entail?
Sure. Go back a little further. So, wh- when we talk about, diagnosis of prostate cancer, one of the things we want to detect is what is the likelihood that the cancer has escaped the prostate, or it's outside of the confines of the what we call the capsule, or the coating around the prostate. And conventional imaging, which was typically done using a CAT scan, or bone scan, looking for it in the bones, was not very sensitive. It didn't give us a good idea for this. Um, Several years ago, a test came out which is called a PET scan, or positron emission tomography, looking at different type of X-ray, where you inject a radioactive, or, we use the word tracer. Some people always call it dyes, but it's not really a dye, but it's a tracer where you inject the radioactivity into the body, and it goes into areas where there's cancer, and in this case, prostate cancer, and it will help us be able to see where the cancer is much better than the conventional imaging. One of the first ones used was something called a prostate scan, which was very difficult to read. And Mike, you probably remember seeing these things and you're like, I don't know what the heck I'm looking at. It kind of looks like a bad map of the sky from the middle of the desert when the stars are all out, and you couldn't really tell what's what on it. Then Axemin came out, or fluciclovine, and that was much better. And that kind of moved the needle, where we could detect cancer not only within the prostate or around the prostate, we could detect smaller lymph nodes that may be involved or bone that was involved in smaller, physical areas than could be detected by conventional imaging. Then it came into this PSMA PET. And PSMA stands for prostate specific membrane antigen. And what that is there are molecules that lie on the surface of prostate cancer cells. And the more aggressive the cancer is, they tend to have more of these molecules on the cell. The PSMA PET will target those and they attach to these PSMA molecules, the tracer does. Then that gets internalized or brought inside the cell. And then the X-ray cameras, these PET scanners, detect them, detect where this radioactivity is, and even in very small amounts. And this has changed everything because not only can we detect cancer within the prostate, we can see it very subtly outside the prostate, very small lymph nodes, bone. And it doesn't mean that you have to have a large volume of cancer. It can be a very small volume. So we can detect cancer, in very tiny amounts of cancer in lymph nodes or in very tiny amounts in the bone that we just can't see with other imaging modalities. And then what makes it even better is if men are treated and if the cancer looks like it comes back because your PSA test, which has been the only thing we rely on to see if cancer's coming back, we can get a PET scan, these PSMA PET scans, and detect it in very early stages if a cancer is returned and actually be able to find out where it is. So it's really changed everything. And, I look back because it wasn't available during my practice years. And I wonder, did I do the right thing on a lot of guys? And now you can only do with the technology that you have at the time. So I can't beat myself up too much about it, but it's just a wonderful addition to our being able to treat these patients. And together with MRI, we're learning so much about MRI use. We're learning so much about the, PSMA PET scan use. And now we're learning a lot. How do we work these together? And what can we do with these, together? The door is wide open and we're learning so much about what we can do. And there's still so much to learn. There's so many unmet needs in the diagnostic phase and the pre-treatment phase and the post-treatment phase and the treatment response phase. Like, it's like, how can we use all this imaging? And, and then we could talk for hours too about, genetic stuff that we can add on top of this. So we are really touching the surface now, and there's been an explosion in technology and prostate cancer over the last 5+ years. It's just amazing, and it's thank God because I think we will make a dent, and helping cure these men, or at least find them so early so we can prevent them from having lethal disease.
Can you expand and add a little bit about the global perspective on the application of PSMA PET imaging? Uh,
Mhm.
I think that it's really fascinating what's going on in other countries, particularly NHS in Europe.
Yeah, I mean, the PSMA PETs, a lot of them were developed in Europe and they started there and um, they've been used there for a long time. There's always the issue of bringing new technology, especially ones that are injectables like the PSMAs, um, to market or for regulatory things and make sure they're safe and they actually do things to help treat and diagnose patients. So a lot of several of these different tracers have been used in Europe for quite some time. And Germany is one of the hotbeds of this, and a lot of it's been developed. A lot of these molecules and these traces were developed in Germany and been using it for a while. They came over to the United States back in the early 2020s and have really taken root there. And there's the regulatory issues are passed. The safety shows that they're incredibly safe. The amount of radioactivity is very minimal that you get when you develop these, even though you're injecting radioactive tracer into the body. So it's being used. It has been used in Europe for longer than here, and it is spreading throughout the world. It's being used in Europe and used in Asia. Australia is a very big place where a lot of these tracers have been developed and used for quite some time. So it's really a worldwide phenomenon, and it has significantly changed the identification, the diagnosis and treatment of prostate cancer throughout the world. And we're touching the surface of this. And it has led to treatment options too. So it's another fascinating aspect that is born out of the diagnostic abilities of these PET tracers.
So, well, before we get into that, because that to me has been one of the biggest game changers in urology, is
Mhm.
what role does PSMA PET play in active surveillance?
Okay, right now, PSMA PET tracers are indicated for two things. They're indicated for men that have been diagnosed with prostate cancer who who hold a suspicion for having metastatic disease. Otherwise, they're indicated in men that have been treated for prostate cancer, and there is evidence of or biochemical evidence of increasing PSA that they have recurrent disease. So right now, that's really what it's being used for solely. The potential for using PSMA PET scan can be kind of what we touched on a little bit before. Is it can PSMA PET alone, in conjunction with MRI and or biopsy, can it be helped to identify men that have clinically significant disease or men that need to be treated? And on the flip side, can it also be used to show that a patient doesn't have clinically significant disease? They may have prostate cancer, but it's not significant. And those are men that would be candidates for active surveillance. So we can use it to identify the aggressive as well as to rule out aggressiveness or help identify from what we think from other clinical factors, abnormal rectal exam or elevated PSAs, things like that, that they may have indolent disease that are good candidates for active surveillance. So this is a potential for PSMA, and people are investigating using it, in that way. We just don't have enough data. And it's difficult to say to somebody, we're just going to get an X-ray and decide either to treat you or not treat you, and we're not going to bother getting a tissue diagnosis. It's just something that's a total anathema to the urologist, is that we just don't know what we have because we're so we've been so inclined to treat based on the biopsy and the tissue that we get. So we have to show that imaging be as good or better than the biopsies that we could take that are much more invasive.
Well, I think that's again, that goes back to our knee-jerk reflex of elevated PSA biopsy treatment.
Biopsy.
And
Yeah. And then the
so,
other, I
I,
think the other thing for active surveillance, I'm sorry to interrupt, but I want to guess because as I always say, I'm getting old and I forget half the things I'm going to say. But for the surveillance part, can PSMA PET or imaging, combination imaging, be used to kind of keep an eye on these guys? Because right now, when we survey men, keep on active surveillance, we are getting periodic biopsies to make sure things aren't changing. That's invasive. And I think a lot of guys will say, I'm just tired of getting biopsies every so often. So can I get an imaging study instead? And that would be wonderful. If we can show again that they're equivalent to getting these biopsies, that would be a huge win. And I think it would be a great move, specifically talking about active surveillance.
yeah, and who knows where the role of AI is going to play, whether it be PSMA PET imaging or biparametric MRIs, as
Or
far as
both.
the continued role of active surveillance. And if we can obviate the role of biopsies in these men on active surveillance, that would be just a tremendous direction.
Absolutely.
So before you were talking a little bit about these advances in PSMA PET technology, but it doesn't end there. It's now we now have the advancements where we can use that diagnostic test and now do what's called a theranostic procedure. Can you talk a little bit about where we're at in radiopharmaceutical therapies for prostate cancer?
Yeah, I mean, the best word to describe these kinds of therapies is that they're really cool. So what they are is when we talk about PSMA PET for diagnostic, again, you inject the tracer into the bloodstream and it goes to the areas where there's prostate cancer, and these X-ray machines can detect where it goes. But what makes it even better is you can attach not just a tracer that can be detected by an X-ray machine, but you can actually put a therapeutic molecule or atom that is radioactive, and the same molecule that brings that tracer to the prostate cancer cell can bring this radioactive material to the prostate cancer cell and treat it right on site. So it's kind of like, if you put, a bunch of keys into the bloodstream and all these locks are there. And these keys go into these locks and part of that key is radioactive. And that radioactivity will kill the cancer, goes right to it. So whether you have a lot of cancer or even minute microscopic areas they might not be able to detect, the idea is that these chemicals or these molecules can go straight to these areas of cancer and destroy the cancer where it is. So if you have metastatic disease, even microscopic metastatic disease, you can still treat them. And this is being done right now. There's one approved agent that can do this. And it's again, it's amazing. It was first used only in men that failed chemotherapy. They were advancing after they had chemotherapy, which is very, very late in the whole treatment timeline. But it's been shown to be effective prior to giving chemotherapy. So it's available to more men. It is not as nearly as toxic as something as like chemotherapy can be. So it can be used. And as we learn more and more about its uses, we may be able to use it earlier and earlier and earlier in the treatment. And maybe someday that would be a form of treatment. There are new types of tracers coming out, being developed all the time. So, again, we're touching the surface of this right now.
Well, there's no question in my mind that PSMA PET technology and the use of radiopharmaceuticals for definitive treatment is really the place to be, and that really is the future. And the sooner we can move that further upstream, in other
Mhm.
words, before it was after chemotherapy, now it's before chemotherapy, maybe even eventually it'll be something that'll be offered for men who have locally extensive disease and have local curative therapies with surgery or radiation and have adjuvant radiotheranostics. I mean, the future
Big.
is now, and I'm really hoping that the protocols will be developed so that these men can get access to these treatment options.
Yeah, having gone to a lot of conferences that talk specifically just about this, it's very exciting. And the discussions that we're having are just what you're talking about, is moving it earlier and earlier. And what can we do to help, prevent these metastatic, prevent metastasis or treat them when they're very early, and be able to, because sometimes you just can't find them. That's a
Well,
problem.
like you said, it's cool, and I agree.
It's
It's
very
totally
cool.
cool. And it honestly, it's been the biggest advance since I've been in practice since the discovery of PSA, which was in 1979. So this is
Yeah.
a huge advance, and I'm excited that we had a chance to talk about it. Prostate cancer globally is an epidemic.
Mhm.
And as I mentioned before, they're anticipating that the incidence of disease is going to double by 2040, which is mind-boggling. So we know that early detection saves lives. We talked about the European trial, which not only shows that the early detection was saving lives, but also it can show that men who got diagnosed and treated have significantly higher survivorship overall. And we also addressed the concept of liquid biopsies and talked about the role of the blood, urine, or saliva tests that are in existence and can actually facilitate the diagnosis of clinically significant prostate cancer. Right now, it diagnoses virtually all prostate cancer, but some of them are actually more specific for clinically significant disease. Do you have any thoughts or discussion you want to add about some of these advents that have occurred in urology?
Um, I mean, there's a lot. I remember earlier in my career, you know, we had PSA was, at the very beginning of my career. So we used that. That was the big thing in urology. And then nothing happened for, decades. And all of a sudden we start, MRI comes along and these PET scan capabilities, genetics and genomics, which is something you never really put together with prostate cancer. It was always breast cancer. You heard about the breast cancer gene, which was discovered in the early 1980s, but now we know, with even the same breast cancer genes, men that harbor it, have a higher likelihood of having prostate cancer and having, a aggressive form of prostate cancer. We've got genomics which looks specifically at the tissue, and can tell you by examining the cells within it how aggressive a cancer is, or the likelihood that it might metastasize, or your likelihood of dying from disease. So there's all of these things that come together, and the information that you can get. It, it may seem, if it was all came out at once, overwhelming, but it's kind of been nice as it's coming out almost in a stepwise fashion where we're learning about this. And now we have these, better blood markers that you're alluding to, that hopefully will help us in the pre-diagnostic phase to identify men that are harboring aggressive or clinically significant disease versus those guys that have indolent disease or non-clinically significant disease. There's so much coming, and
And in
it's an
addition to that,
exciting place to be.
do you have any predictions or hopes that you'd like to talk about for the future of active surveillance?
I think in active surveillance, my hope is, in the diagnosis and surveillance um, of patients that are good candidates for active surveillance or are on active surveillance, is that we can eliminate biopsy, that we have better ways, non-invasive ways to follow them, whether they're um, blood tests, urine or salivary tests, even or imaging tests, that we can eliminate these biopsies, which are very invasive. And you talk about anxiety of just having the cancer, to the anxiety of what it's going to take to follow them and not really knowing or having good indications yet, what's going to happen in the future. So if we can predict that better, what's going to portend in the future. And I think that's it's on my top of my wish list for the men with active surveillance, is to be able to eliminate that anxiety, so you can say to somebody, we can do these tests, you come in once a year, I can tell you with confidence you're fine, go home, I'll see you next year. And I mean, how better to have that relationship with a cancer patient than to tell them, go home, don't worry about it, you're more likely to get hit by a bus than you're ever going to have chance getting, dying from prostate cancer. And where that's come just with what we have now from Michael when you and I were kids. It really has come a huge way. We used to all sit around and cry when one of our relatives was diagnosed with cancer of any kind. And now there's so much hope, and the future is bright. Uh, and AI is going to help. There's so many areas you could stick it in, apply it here, and we're going to see more and more of that, um, with all sorts of diagnosis and treatment of prostate cancer.
I totally agree with you. I think that active surveillance is evolving right before our eyes. When someone says, "What's your protocol?" I said, "Don't get married to it. It's going to be changing in the next 6 months because the protocol keeps getting better and better. It gets less invasive. It trusts more of these imaging technologies that are improving day by day. We have data that's coming out of Europe that's proving the PSMA PET technology is here to stay and is such a wonderful technology. MRI technology is improving, and the role of AI biparametric MRIs are on the horizon to replace multiparametric to make it less toxic to the male patient. And I really think the future is now. And we have all these opportunities now to really take much better care of our patients who select active surveillance in partnership with their treating physician. And it really is a wonderful future, I think, for prostate cancer survivors. And I think the technologies just keep getting better. I think patients need to know they have options, and it's important that they go to a physician that promotes all of the opportunities available to them and stays involved in their care. One of the things that a lot of men who are diagnosed with prostate cancer find is that they'll get diagnosed and then after a year, they don't see their urologist anymore. They need to keep seeing their urologist, even if it's just to get a PSA test and discuss the results, because the technologies keep changing significantly. And it's important that they see their urologist. I know that the data out of music, the Michigan Urologic Surgical Improvement Collaborate, is that after a year, the majority of men don't see the urologist anymore because they dismiss them from their practices and they go back to their primary care doctors. So don't do that. Stay in touch with the urologist, see them on a regular basis so that they can keep you abreast of any of the updates in the management of your prostate cancer, whether you're on active surveillance or you've been definitively treated. Because if there is a local recurrence or metastatic recurrence, you know, you have somebody there who's going to be in your corner and can get you the earliest and best technologies applied. So I want to thank you all for being here tonight. I want to thank Dr. Todd Cohen from Blue Earth, who actually shared all of his knowledge and expertise with us. And I'm glad to see that he's unfortunately younger than I am, but it's great to have him here and share all of his expertise. For those of you who are looking for additional resources, um, what I would recommend is you can go to the Michigan Men's Health Foundation website or the NCCN patient website for further support. Um, Somebody did ask a question before I sign off. Said, can you please recommend a quality facility that offers biparametric MRI as my urologist? You can literally get a biparametric MRI anywhere. And if you want it AI enhanced, there is a company called AI Bot Image that will offer you to get your image reviewed using their AI technology. And that resource is available, and you can look that up online. It's called Bot Image, and they do biparametric MRI AI resources. Um, I want to thank our sponsors, Lantheus, Blue Earth, Corewell Health, NeoKing Physical Therapy, and the American Cancer Society. Our foundation activities are growing. We are developing a mobile men's health clinic known as the Toolbox that'll be traveling throughout the state of Michigan to underserved communities and first responder facilities. We have partners within the community that are going to be joining us to be part of our men's health mission and help us screen for prostate cancer in the underserved communities and improve the health of the men in our communities. And I just want to thank you for joining us this evening. Thank you to Dr. Cohen, and thank you to our sponsors. And be well and have a good night.